Hello, my name is Krista Gomes, and I'll be discussing the use of ultrasound to diagnose rotator cuff pathology. Next slide. So just to kind of start off, I'll go through a brief background, brief review of anatomy, how to actually perform the ultrasound, some pathology, and some limitations of using ultrasound. Next slide. So starting with a little bit of background. So shoulder pain is one of the most common complaints prompting patients to seek treatment, usually in primary care offices. Up to 70% of shoulder pain can be attributed to some sort of pathology in the rotator cuff specifically. Of course, the differential can be very, very broad. There can be tendinopathy, a tear, osteoarthritis. It can go on, but different clinical exams can be useful in aiding in the diagnosis of rotator cuff pathology. However, some cases during these clinical exams, the shoulder pain can be a poor predictor of the actual origin of the pathology itself. Additionally, usually you're going to need radiographic evidence to actually confirm the diagnosis. Next slide. Multiple studies have demonstrated ultrasound's high sensitivity in actually diagnosing rotator cuff disease. There have been studies going back to as early as the 1970s. The potential pathologies that could be identified using ultrasound alone include tendinopathies, rotator cuff tears, partial and full thickness, calcifications in the tendon itself, and impingement if you were to do the exam dynamically. The advantages of using ultrasound, of course, are cost, efficiency, limitation of radiation exposure, and ease of use in the inpatient and outpatient side. So this was a 2009 meta-analysis that compared MRI to MRA2 ultrasound in identifying different rotator cuff disorders. Just some of the conditions they looked at: tendinitis, rotator cuff tears, and bursitis. This analysis revealed that there was actually very good diagnostic accuracy of all three, ultrasound, MRI, and MRA, in characterizing full thickness rotator cuff tears, while the overall sensitivities did decrease with partial tears. They found that the sensitivity of the MRA was found to be slightly higher than MRI ultrasound for actually diagnosing partial thickness rotator cuff tears. Next slide. This was another meta-analysis. This one was done in 2011, and this was hoping to look at the accuracy of ultrasound in detecting partial and complete rotator cuff tears, specifically, not including the other disorders seen on the prior slide. So this was analysis of about 6,000 patients over 62 studies, and they found that the ultrasound had a higher sensitivity for detecting full thickness tears and a little bit lower sensitivity and specificity for detecting partial thickness rotator cuff tears. Next slide. So here's just a brief review of the anatomy, the anterior and posterior view of the four muscles that make up the rotator cuff. There's the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. Next slide. Just briefly kind of going through some of the technical aspects on how to actually perform the ultrasound. For optimal positioning, you want the patient to be upright, ideally in a revolving chair. This is just to allow for full 360-degree access to the shoulder during the examination. And then the transducer is usually a linear probe, should be moved slowly as not to miss any sort of abnormalities. It's always important to keep the probe at a 90-degree angle to the structure of interest, because this will limit any variation in the angle that might alter echogenicity, leading to false positives or false negatives during the exam. Of course, the stability of the examiner's hand during the exam is important to keep. And then lastly, it's always good to have just a stepwise standardized sequence to follow, just to ensure that you're not missing any sort of structure. So one proposed system could be starting with the biceps tendon, moving to the subscapularis, then the supraspinatus, and then the infraspinatus and teres minor, and then lastly, doing more dynamic maneuvers in the end to evaluate for any sort of subacromial impingement. Next slide. So this just kind of outlines the preferred patient positioning to look at the biceps tendon. Here the elbow is flexed with a forearm supinated, and on the right hand side of the screen up top you'll see a short axis view of the bicep tendon, and then below you'll see the long axis view of the biceps tendon. Next slide. Here is the preferred patient positioning for examining the subscapularis tendon. Here the elbow is a little bit flexed and the shoulder is actually externally rotated. And on the right you can see a long axis view of the subscapularis tendon. Next slide. This one highlights the preferred patient position for examining the supraspinatus, and this is actually called the modified Kras position. So the arm is slightly extended and internally rotated. And on the right, you'll see the normal supraspinatus tendon in the long axis above, and then in the short axis below. Evaluation of the supraspinatus tendon is particularly important because it's the rotator cuff tendon that's most frequently associated with tendinopathy or tears. And I also wanted to point out that it's important to understand the layers of alternating layers in the ultrasound, because identifying the layers can help when there are any interruptions indicating a pathology. So kind of starting on this top image, at the very top you'll see skin. And then below that, you'll see the deltoid, which is going to be hypoechoic. And then there's a thin layer of peribursal tissue, which is going to be hyperechoic. And then right below that will be the bursal fluid, which will be hypoechoic. And then you'll see the rotator cuff itself, which will be hyperechoic. And then right below that is going to be the articular cartilage, which will be hypoechoic. And then the cortical bone, which will be hyperechoic. So just keeping in mind these layers can help identify when there's any sort of interruption in the layer, for example, if there were a tear. Next slide. So just to start off with a couple examples of some pathology that you'll be able to identify. So first is rotator cuff tendinosis. So this is going to be kind of ill-defined tendon swelling, usually hypoechoic or heterogeneous, kind of like pictured here with this yellow arrow. So here you're not usually going to see any sort of cortical irregularity that you might see with a tear. And this image shows a longitudinal view of tendinosis of the supraspinatus muscle. Next slide. The next pathology that you could potentially identify is calcific tendinopathy. This is a common finding and a common cause of shoulder pain. You can see calcium hydroxyapatite deposition into the rotator cuff, usually the supraspinatus. This will lead to a hyperechoic mass. Because of the calcium deposition, you may or may not see some posterior acoustic shadowing. Symptoms are largely due to mass effect, which can lead to impingement, limit abduction, or the mass can actually extend into the bursa, creating acute pain. Next slide. Lastly, I wanted to touch base on rotator cuff tears that you can see on ultrasound. Uh, like I mentioned before, most involve the supraspinatus. This is an image of a partial thickness tear, and in these cases you'll see a hypo or anechoic region that's usually well defined, as opposed to tendinosis, where it was more ill-defined, a hypoechoic region. You may see some cortical irregularity with a partial tear, but if the tear does contact the hypoechoic cartilage, the tear usually fills with fluid, and you can see increased echogenicity of the cartilage, and this is called the cartilage interface sign, seen on the right side. Next slide. And this is just an image of a full thickness tear. You can also see the cortical interface sign as well, and you'll often see cortical irregularities. For a full tear, the extent is from the bursal surface all the way to the articular surface. Next slide. And just briefly going over some limitations. The experience of the clinician actually performing the ultrasound should definitely be taken into account, because even with more experienced providers, it can be very difficult to actually visualize the entirety of the rotator cuff, and if you're not able to see all of the structures, that might reduce the sensitivity and specificity. And although, like I mentioned before, the sensitivity and specificity of using ultrasound for diagnosing full thickness tears, there might be some controversy as to the use of using ultrasound to diagnose partial thickness tears. Slide. And those are my sources. That's all.